Can you not hear us, anybody?
Yeah, I can hear you.
Oh,
Yeah,
okay.
I can hear you well.
Some people haven't got any sound. I think Jane's not got any sound and somebody else. Let's give it a minute or so longer, Jill.
Okay.
I'm aware we've got quite a few people that have booked on, but we are recording today's session, so I think we've only got an hour. So we'll crack on. Thanks for joining everybody and welcome to this month's Lunch and Learn around palliative and end-of-life care. I'm Pauline Love, I'm the end-of-life lead for the ICB, and Jill Davis is my trusted sidekick, if you like, and she does all the talking while I do all the monitoring, and she's going to be talking today about therapeutics and pain management. Over to you, Jill, if you want to introduce yourself.
Yep, sure. So I'm Jill Davis, Palliative Care Clinical Lead and ANP at DHU, and I work on and manage the Palliative Care Urgent Response Service that hopefully some of you will have heard of. So yeah, we'll crack on with today's session. So we're going to have a quick look and talk a little bit about the Kalman gap, look at what pain is, pain assessment, how you might manage pain, and look a little bit about prescribing in palliative medicine. And there's a case study that kind of underpins what we're talking about as we go through today. If you've got any questions, please pop them in the chat. So you're all right to monitor that, Pauline, as usual?
I am.
And yeah, or just jump in with a question at the minute. We're not a big enough group that's going to cause any problems. We'll try and stop at the end for any questions as well as we go through. So, don't know how many of you have heard of Kalman. He very much described a relationship between what somebody is expecting around a particular situation that they find themselves in. And it's kind of that expectation and the actual situation and looking at the balance between that. And he found out the smaller the gap between the two, the better somebody's quality of life. So if, for example, you've got a major physical or psychological issue that's going on, you can still have a good quality of life because the expectations of the individual are lower. So he talked about this in terms of a gap theory, and very much I think our experience in terms of palliative and end-of-life care is if you actually tell people what to expect, they tend to cope with things much better than if they're left wondering. So in essence, that's what the Kalman gap is. It's very much about trying to increase and maximize somebody's quality of life over a period of time by looking at their hopes and aspirations. And as somebody's hopes or aspirations perhaps get less, if we've talked about that and we've prepared them for that fact, then actually their quality of life tends to be better because their expectations are much more realistic. So basically, in essence, it's very much communication underpins everything that we do in palliative and end-of-life care, and having those conversations with patients and families about what they might expect, what's realistic or not, actually helps them cope and have a much better quality of life. So whichever symptom we're looking at, managing those expectations is something that is really important and something that we can't stress enough. So honing that down a little bit to look at pain. So pain is a symptom. It's not a diagnosis in itself. It's a symptom of lots of different other diagnoses that patients may have. And it is when basically it's as simple as when somebody says that something hurts. We should be believing them. We shouldn't be just looking at somebody's facial expression. Lots of people dealing with chronic pain cope with extreme amounts of pain, but don't necessarily show that in their facial expressions or in their behaviour because they've learned how to manage it. So it's very definitely about believing somebody, and it's listening to them when they say that something hurts. For most of us, we will have all had pain at some point. That might be cracking your elbow on something, which I did this morning on the door to the bathroom. And that's that sort of sharp, intermittent pain, to having something that's much more longer lasting. But I think we can all agree it's a fairly unpleasant sensory symptom, which can sometimes have an emotional aspect as well. And it's often associated with actual or potential tissue damage, or that we describe it in terms of such damage. So I've got a bruise on my elbow from cracking my arm on the bathroom door this morning. For some people, it is very much what we would describe a total experience. So it is a personal experience that has physical, psychological, social, and existential dimensions. So it's not just about having a pain, it's about what that pain might mean or what it might signify to that particular individual and the impact that that has on the rest of their lives as well. So, for example, you may have a patient who's been diagnosed, I don't know, breast cancer years ago, that has done very well. They've technically been cured, but every time they get a niggle or a back pain or something else, they might automatically associate that that's metastatic disease pain, whereas it might just be that they've been gardening and they've overdone something. So again, it's very looking at that experience, what it signifies to that individual, which again can help us to manage their symptoms and their experience more effectively. So optimal pain management is very much compromised if any of those aspects are neglected. It's very easy for us in most cases to concentrate on the physical aspects of pain, particularly if you've got somebody shouting out, but those psychological, those emotional, those social and spiritual impact of that person's pain is something that's very real and something that we need to acknowledge. So good old Dame Cicely Saunders, who was the founder of the modern hospice movement, came up with the concept of total pain. And it's just a very easy diagrammatic form, but you can see that overlap in the middle. If somebody's experiencing pain in all those 4 different aspects of their life, can suddenly become very, very onerous for that individual, that they feel they're suddenly not coping anymore. So it's important we recognise that issues in one area can have another impact in another part of that person's experience, for want of a better expression. So honing in a little bit on symptom management as such, as I said, we very much need to consider the whole person in this. Symptoms are never purely from one area or another. It's never just a physical sensation. It will have impacts into other areas of somebody's life, and all symptoms and treatment will have an impact, be it on the patient themselves or on family members. And I've often had patients say, actually, I cope with this better than my wife does. I think when you are looking on at somebody who is experiencing pain, a lot of relatives or carers can feel very helpless, for want of a better expression, because there's not always anything they can do to make it feel better. So it very much feels out, and watching somebody that you care about suffer in a particular way can be very, very hard for them to come to terms with and to try and accept. When we're thinking about pain management, it's very much about evaluating that person's symptoms, and if we can, honing in and trying to identify what the cause might be. I mentioned communication earlier, and I can't stress that enough. It's something that's really important in terms of trying to get history and find out what's going on, but also in terms of trying to get somebody to adhere to any management or treatment plans that we might be coming up with as well. When we're thinking about symptom management as a whole, it's very much about correcting what we can correct. So it's looking at what might be a reversible cause. It's also thinking about non-drug management as well. So if you've got a patient, I don't know, with metastatic cancer, could we think about radiotherapy if their pain's been escalating, if they've got metastatic bone pain, for example? For some people, they'll respond really well to things like complementary therapies. For others, it might be things like heat or coldness. It might be a TENS machine, so providing some sort of stimulation. And it might be really basic things like just changing somebody's position, making sure that they're on the right sort of mattress to try and make them as comfortable as possible. And where we put cushions, making sure people have got backrests that they can sit up appropriately. Those sorts of things will help massively. And none of those are particularly drug treatments as such. If you've got somebody who has been taking regular ad hoc medications, then we might very much need to think about starting them on something regular, so some background analgesia. And if we are doing that, still making sure that we've got a patient who's aware of what they can take in between times if their pain is still not controlled. And I think it's about very much reviewing that regularly and adjusting treatment accordingly. We often see, I saw a patient this last weekend who'd been prescribed or was on quite a high dose of a transdermal patch, but their PRN dose in terms of their just in case meds that had been put in place hadn't been adjusted with the fact that the patch had gone up over the last few weeks. So it's making sure that if you're increasing somebody's background analgesia, that their PRN dose, whether that's an oral dose and you're not at just in case medication type at that moment in time, or if they've got just in case in place, is increased in line with that. We so often find that people have had escalating doses in their regular pain relief, but those PRN doses haven't gone up in line with that, and that can be why they're struggling as well. Very much it's making sure that we plan in advance. So thinking about symptom management as a whole, it's making sure we've got our respect forms in place. Hopefully you're all starting to use the digital respect platform now as well, and making sure summary care records are up to date, that we've got resource status that's identified, that we are thinking about where somebody wants to be cared for and where they want to die, and making sure that that's acknowledged and written down as well, so that as a team that are going in, and particularly from my point of view from an out of hours clinician, it's about making sure that we know what the plan is so we can try and work with you all to make sure that that happens. It's thinking about things like advanced decisions to refuse treatment, lasting power of attorney, again, if it's earlier on in somebody's illness, thinking about those other aspects of advanced care planning that can be important for patients and families. And as I say, very much utilising the Derbyshire Shared Care Record. We are very hopeful that with the onset of the digital respect form, that is going to be that single form of truth, and that we're not going to see lots of different plans knocking around in patients' homes. But we also appreciate that those forms are going to get adjusted as you are seeing patients. We don't expect you to go in and do every single patient who's got a respect form and convert that into a digital plan straight away. But as things change, as their condition gets reviewed, then doing that certainly helps us in terms of urgent care and also ambulance clinicians as well, to make sure we're following your plan and we're doing the right thing. The other thing to stress is you can always ask for help if you are unsure about somebody's management. There's a huge amount and raft of resources, and they're included in the resource list at the end of the presentation for the Derbyshire Alliance for End of Life Care website and their toolkit. Huge amounts of information in there on all sorts of symptom pains management, respect, advanced care planning, all sorts of different things. So it is really good resource for you to use. There's also educational elements in terms of further training that are advertised on the toolkit as well. You can always go to on-call palliative care advice. You can find out who that person is through the switchboard at any of the main hospitals. So there'll be a different clinician on in the south of the county to the north, but Chesterfield Royal, Derby Royal Hospital switchboards will point you in the direction of who you need to be speaking to. You can also, during the daytime, contact Nightingale Macmillan Unit or Ashgate Hospice, again, direct for some help and advice if that's what you need. But as I said, you're never on your own. There's always somebody that you can go to for advice. So honing down a little bit in terms of pain management, we first need to think about assessing somebody's pain, and it's important that we do that right and we do that comprehensively, because that gives us a much better idea of what we're dealing with. I'll often describe particularly pain control, but any sort of symptom management, and anybody that knows me well will probably say, because that comes from what I enjoy doing, but it's very much almost like mixing a cocktail. It's finding the right combination of things that are going to work for that individual. No person's pain is exactly the same. It's very much finding out what works for that person, what doesn't, and tweaking things accordingly. So as part of that assessment, it's really important that we find out, or we think about what the pain might be due to. So what's the site of the origin? What do we think might be causing it? So what underlying conditions has that person got that might have been impacting on that? Or has somebody just been doing some decorating or gardening and suddenly exacerbated something by an activity they're doing that's not necessarily, might just be musculoskeletal rather than something that's related to their disease? It's thinking about the nature of that person's pain, and I'll go through Socrates in a minute, but I'm sure you're all aware it's just a mnemonic for pain assessment, and it's one of a number of ones that are out there. Is that pain due to that person's cancer, or is there another cause that that person's got that might be impacting on their pain? And as I say, don't forget that concept of total pain. It's the impact that it's having on that person. We've got numerous pain tools and pain scores that are available out there as well. I'll touch on a couple as we go through the presentation. At the bottom of the slide there, you'll see sort of the smiley face or unhappy face scale at its very basic format. That you can get kids to do, that you can get people with a learning disability to often do, quite a visual thing. But how's that pain making you feel? Is that improving? So it's giving you a smiley face, which is what we're hoping the outcome will be at the end of our intervention. Or is it somebody who's got a very frowny face that's really struggling with symptoms? So just a very basic visual pain score that some people use. You might have also seen the scoring tools like score your pain from 1 to 10. I don't know about anybody else, but I thought about that this morning because I knew we were doing this session today, to think how I would have described the pain from cracking my elbow on the bathroom door this morning. And at the time, it really, really hurt. Now it doesn't unless I catch my elbow on something. So I don't know about anybody else, but I think trying to score a pain is really difficult. And it, again, will depend on what your on what your interpretation might be. And certainly in the past, I've asked patients to score. I've maybe asked consultants to come along with me to assess a patient. And although they scored their pain at 11 out of 10 when I saw them, they might be scoring it at 4 out of 10 by the time the consultant goes to see them. So sometimes, again, it can be asking people what's important. It can be getting them to describe how intense that pain is. So somebody says this pain is excruciating, then you've got an idea that that pain is pretty bad. Whereas if somebody says, well, it's just a bit of a niggle, it's just annoying me a little bit, again, that can help put things into context. But it's finding out what works for you. It's finding out what works for that individual as well. And I quite liked this, describing pain only in terms of its intensity is a bit like describing music only in terms of its loudness. It's much more involved than that. And if you like listening to music, there'll be all sorts of things and nuances that you can think of when you're listening to music that you can compare, that again impacts on your overall interpretation of whether you like that music or whether you dislike it. And pain management is very much the same. So it's not just saying it's a scale of 1 to 10, it's very much about that impact on that individual, and it's about what the effect it's having on them is. So I said I'd mention Socrates a little bit more. I'm sure this is something that a lot of you are already aware of. So the S stands for site, and it's about where the pain might be where it's located. The O is for onset, so when and how did it start? So how long's this been going on for? C is very much around characteristics of the pain. So what's it like? Asking that person to describe it, and they might need prompts to be able to do that. So again, if you have been a pain, and we're often in a position that we're asking people to do that all the time, it's not always something that's very easy, you know. So asking somebody a prompt, is it an achy type pain? Is it there all the time? Does it burn? Does it shoot? Does it feel like you're being stabbed? Again, will help you get a greater understanding of what that pain is, what might be causing it, and what the best treatment outcomes might be. The R stands for radiation. So does it go to where, or is it going from anywhere? The A is for association. So again, thinking of that whole person approach, but how does it make you feel? Are there any additional symptoms that are also impacting on this particular perception of how bad the pain is at this moment in time? And again, linking back, as I said before, that example is that association that I've been told I could get pain somewhere else if my disease spreads, that automatically that back pain then becomes significant, that this is metastases rather than something that's much more likely to be the case. So again, it's that impact. The T is for time. Is it there all the time? Is there a time of day that's worse, or are there activities that make it worse as well? If it is present, how long does it last for? If somebody's taking some analgesia for it, how effective is that analgesia and how long is that lasting for? So if somebody's taking some paracetamol, or if they're taking some Oromorph or some oxycodone, what's the impact of it? Is it working? Is it lasting? And how long does it last for? The E is for exacerbating or relieving symptoms. So again, it's often going back to patients themselves and asking them what helps. We are often masters, if we are the patient, in terms of finding out and knowing what works best for us. So asking the person for their experience, what have you done? What makes it worse? What have you found that helps? Will, again, hopefully direct you a little bit in your management plan. And the other S at the end is the severity. So again, we've talked about pain scores and things. Just having a think about that, finding out from people what the most effective way of doing that might be. But again, just getting somebody to describe their pain in terms of intensity in words might give you a good indication of what it's like. So as well as people who can tell us what their pain might be, a large proportion of people that we're all caring for and we come across in everyday practice might not be able to communicate with us as effectively, and might not be able to understand the questions that we're asking of them. So again, there are things that can help us to pick out or perhaps identify when pain might be an issue for a particular individual, even though they can't tell us themselves. So facial expression is a good one. We'll all moan and groan or pull a face, perhaps when we're getting up and something hurts. That's generally me getting out of a chair. Later on, I'll be pulling a face because I've got a back problem. So facial expression can be a good one. If somebody's groaning or crying out or making whimpering noises, particularly if you're doing any intervention with that individual, might also indicate that there's a problem there. You can think about the physiological or observe the physiological changes that are associated with pain as well. So are there changes in breathing pattern? Does somebody start breathing more rapidly? Are there changes in somebody's mood and changes in somebody's behaviour as well that might indicate that pain might be an issue? So you might have got somebody who's always been up and walking around who suddenly stops and sits still in a chair, which is not their normal behaviour pattern. Or you might get somebody who's just pacing around who really can't get comfortable, where normally they'll sit quite relaxed. So again, it's looking at changes in mood, it's looking at changes in behaviour and anything that's different to the norm. Is somebody getting more agitated or showing signs more of a temper, where again they've always been fairly placid before? Is there a lack of concentration with activities that people would normally manage without a problem? Has somebody stopped having eye contact with you, or is looking away when you're asking questions? Are they refusing care or refusing food, diet and fluids? Are they very reluctant to move? And are they bending over or favouring a particular side when they've started moving? Again, that's the change from the norm. Are people sat there that are suddenly rubbing arms, legs or backs? Again, a change in their normal behaviour pattern. And there are always things, particularly with patients with dementia type diagnosis. We've got Abbey pain and we've got Distat duals that may also help identify. And again, it might be part of our role in encouraging staff that are perhaps with these patients a lot of the time to get them to be monitoring for those things as well, so that they can be seen for changes in behaviour. So just a few cues there for you to think about. The good old World Health Organization analgesic principles, or analgesic ladder, as it's often termed, is still very relevant today, although it's been around a long time. So if somebody starts with pain, then we would normally be looking at the simple or step one type treatments, and that would be non-opioid analgesia, things like paracetamol, ibuprofen, stuff that you can buy over the counter. And that may need to be given with or without an adjuvant analgesic as well. So again, it's recognising, as I said before, not every patient responds to the same pain relief in the same way. Different pains respond better to different types of treatment. If that mild analgesia isn't working, then we might need to step it up a level. So we might be looking at the weak opioid. So we might be looking at things like codeine, Again, but there's always a caveat. Personally, working in palliative care for 30 odd years, I don't particularly like codeine, although some people love it. It tends to have a massive side effect profile, the biggest one being constipation, which particularly in elderly patients can be a real issue. But again, some elderly people absolutely love it and respond really well to it. So it's thinking about those sorts of treatments. Another one in that category might be something like tramadol as well. And if that's not working, then we might escalate up the ladder and we might go to our stronger opiates for our moderate to severe pain. And again, with all these, it might still be with other non-opioid analgesias. So I've looked after patients in the past, particularly in oncology, who might be on high doses of opiates, but they would still know when they'd missed their dose of paracetamol because it still worked on an aspect of their pain control. So it's not just going up the ladder and forgetting about the others. The others can still have a place in managing somebody's symptoms. And we might need to think about those adjuvants that we're prescribing along the way. So again, if you've got a patient perhaps with a nerve pain, for example, not always very receptive to opiates, and you may be going up that analgesic ladder, still not having much benefit for their pain, but all we're doing is making them sleepy, or we're giving them side effects from those opiate drugs. So sometimes if things aren't working as we would expect, it can be a time to step back, take a look, and find out what we think is working rather than just blindly going up that analgesic ladder. So types of pain that we may be looking after people with are listed on there. So we might have somebody who's got an acute pain. So if I've decided to go wild in the garden or decorate my whole house when I'm not used to doing that, I will probably get some aches and pains somewhere. So I'm going to get an acute pain. It may be, I've already mentioned, I've got a back problem. So I've got an element of chronic pain there that is there all the time, that I'm used to, that's the norm for me, for want of a better expression. But I also know then that if I've got that pain and then I decide to decorate, or I decide to clear some stuff out in my garden, which I've done this year, I might have an acute on chronic pain as well. So I've got that underlying issue, but I've done something else, which has given me an acute pain on top of that as well. So it's thinking about those sorts of things. It's recognising people might be fairly well controlled most of the time, but they might still get breakthrough pain. So we might have somebody on a regime, but it's not perfect over the time, over every activity that person does. And it might be that they do something again where they need a little bit extra and a bit more of a top up. We then might be dealing with patients with nociceptive pain or non-nociceptive pain or neuropathic pain, and we'll look at those two in a bit more detail now. So nociceptive pain is caused by invasion and or destruction and or pressure on local structures. And it's usually pretty localized and it doesn't particularly radiate anywhere else. So types that we would typically see are superficial type pain. So it's just under the skin, it's on the surface, it's localized. Often might be described as an ache. So again, when I cracked my elbow this morning, I got that acute pain. It then left me a little bit achy. It's now not massively bothering me unless I put any pressure on it. So it's that superficial type pain that I'm experiencing. So it's like that bruise type stuff. It might be a deeper pain than that, so where we've got bone or muscle involvement, and that will often be people that say they've got this nagging, they've got this deep ache, or it might be that they're saying they've got a sharp stabbing type pain, particularly when they move in certain directions. And we might be describing that visceral type pain. So if you think somebody who might have got something like liver capsule pain, for example, because your liver's in a capsule, there's no way, if it's inflamed, for it to go. So you're getting that pressure that's building up inside that particular organ, which can be quite distressing for patients that we see. So that's a little bit on nociceptive pain. And if we think about neuropathic pain, we're looking at pain that's caused by pressure on and or destruction of peripheral, autonomic or central nervous system structures. So we're generally looking at pain that perhaps radiates along a whole nerve distribution. So anybody that's had sciatic type pain will know that that pain might come from your back, but you might experiencing it all the way down your leg. So it's that referred type of pain that we often get that goes down that nerve. It's often associated with dysesthesia or a dull sensation, reduced or absent feeling, so that element of numbness, perhaps to somebody experiencing the opposite, which is allodynia, where they are incredibly sensitive to touch or pressure or those sorts of things. So again, it might be somebody's quite comfortable at rest, but when they get up and start trying to mobilise, that's when the pain becomes its most acute. So it's very hypersensitive at that point. So going back to our principles of pain management, you can think about your Socrates assessment. So looking at what's causing that pain, what it's like, where it's going, looking at how long it lasts for, whether it's there all the time, whether there are exacerbating factors. So perhaps pain is worse on movement, for example, anything that makes it better, and how bad and how intense that pain can be. So we're looking at the causes, we're looking at the type of pain as part of that pain assessment. We then need to think, when we've thought about what might be causing that particular area of pain, we then might need to be thinking about planning somebody's treatment. And that's very much should be done involving the patient and explaining the plan and their aims. Again, going out on palliative care urgent response service, I might look at somebody's summary care record and see that they're on all sorts of analgesia. But when I talk to the patient, they actually tell me, I'm not taking that because it doesn't do any good. I've stopped taking that because that makes me feel awful. It's making me feel sick. That actually sometimes what we think a person is taking is very far from what we actually find in reality. And it's really important, for example, if you are starting a patient on an opiate, that you warn them that they might feel sick for a day or two, or you warn them it might make them feel particularly sleepy. If again, it's going back to Kalman gap and managing expectations, if they know what potential side effects for and how long they might last, or that you've given them something to help manage that side effect, they're much more likely to stick with the plan than they are if you've not warned them that those things are an issue. So again, it's very important to involve somebody in the plan. And you might need to be flexible in your approach. I've gone into patients' homes on many occasions and thought, oh, I know exactly what might sort this out. We could put a syringe driver up or whatever else it might be, only to have a patient say not having one of them up, and no amount of talking about it or education or anything else will make them change your mind. So you may, again, need to go back to square one, and you might need to look up and come up with a plan that is suitable and acceptable to that particular individual, even though you think you might have got something that might work better. We need to set realistic goals. So certainly thinking back to the time in my career where I worked at Weston Park, looking after a lot of oncology patients in Sheffield, I would get patients referred to me, and when I turn up and say, oh, you're pain nurse, aren't you? You're going to come and get me comfortable. And that's how I've been sold as. And although that's what I hope the end of the consultation or the end of the treatment plan is going to produce, I never promise a patient that I'm going to make them completely pain-free. I will always say, this is what we're working towards. I'm confident that we can make you feel significantly better, but I will never make a promise because we can't always deliver on it. And although in the majority of cases we can get somebody comfortable, and hopefully they're comfortable all the time, again, it's about managing expectations. It's about setting realistic goals. So don't set yourself up to fail, I guess is what I'm saying, is the message from there. Implement the plan, keep evaluating and reviewing it, and document your interventions accurately. So we need patients that have got either drug charts or instructions with clear instructions on, and that we've got clear evaluations there that are on record. And record keeping is an issue in itself. You'll all be aware that urgent care out of hours services are on Adastra when we go and do a home visit. So I can't see what you've written on System 1 or in your EMIS care plan. And that does cause issues. And again, that's where if there is anything specific that we need to know, be about pain management or a patient's care, that until we get on the EPACS, the electronic palliative care coordination system, which is hopefully on its way in the coming months, then it's important that anything we significantly need to know to manage that patient effectively is documented, and you can still use the special notes facility for out of hours clinicians so that we can see and we can follow a plan that you've put in place. So thinking about pain management again and the types of pain and words that might be used to describe it. So generally soft tissue pain, patients will describe it as that area is throbbing, that it feels tender, that it might be a bit achy. So anybody who's describing pain in that way might indicate that there's a soft tissue injury. Heaviness or tightness will often be used to describe edema. So if somebody's got really swollen legs, then moving them becomes difficult. I've had patients that have said to me, it feels like my skin's going to burst because it's so tight. Thinking about edema. Nerve pain is often described as throbbing, burning, toothache type stuff, pins and needles, might be an element of numbness there. Raised intracranial pressure, particularly if we're looking after people with brain tumours, they might describe it as having a tight band around their head. So it's quite restricting and it's a thumping type headache that's often worse in the morning when they've been laid flat. Bone pain, annoying or a deep achy type pain, and colicky pain is that cramping, exhausting, griping type pain that patients will describe. So when we're thinking about our choice of drug treatment, then we need to think about the most appropriate route first of all. So there's no point in setting somebody on orals if actually their swallow is starting to deteriorate. We might need to think about a different option. We might need to think about somebody's physical limitations. Can they actually unscrew the cap on the bottle when we are thinking about somebody's analgesic requirements? Can they pop the pill out of the pack? About dosage boxes and other means that they've got access to that pain relief, that means that they're much more likely to take it. We need to think about whether somebody has got an issue with nausea and vomiting. Again, they might have excruciating because they can't take their oral analgesia because they're throwing it up and we don't know what they're actually absorbing. So again, it's thinking about those sorts of symptoms again that have an impact on what we do. Thinking about conversion charts and equivalent doses, again, Derbyshire Alliance has got that information on it. It's got a great opiate conversion chart, including patches. We need to think about somebody's compliance or adherence to the plan. We've already mentioned that. We might need to think about somebody's renal or hepatic function as well, and we'll talk through that when we get particularly onto the opioid section. And we need to make sure that our PRN doses are available, and as I said before, that they're increased in line with any regular background analgesic increases as well. And we might also need to think for some people where pain is particularly a problem on movement, but they're comfortable at rest, that we might need to be giving them preemptive advice. So half an hour before you're going to have a wash, that's when you need to take some of your short-acting pain relief so that hopefully we get you more comfortable while you're having that period of care, and then you can settle down again. Some patients I've looked after, if I were to try and get them completely comfortable all the time, including movement, they would be comatose because they're needing that amount of analgesia to try and help them move. So again, it might be working with patients to come up with a plan that's acceptable, and we might need to think about preemptive or pre-movement analgesia. When we think about going up that analgesic ladder, we might need to convert opiates to oral morphine equivalents. So, for example, codeine dose of 60 milligrams QDS would be 240 milligrams in 24 hours. If we divide it by 10, that gives us our rough equivalent of a morphine dose, of an oral morphine dose. And similarly with tramadol, the rule of thumb is to divide by 10. Thinking about non-drug alternative measures, so patients can be managed successfully with a mixture of pharmacological and non-pharmacological treatments. We might also need to think about things like steroids. We might need to think for some patients about anaesthetics. Again, I saw a patient last weekend who's waiting for a nerve block as part of their pain management. So they've tried most other things which haven't been massively helpful. We might need to think about antidepressants, so things like amitriptyline. We might need to think about our anticonvulsant drugs as well, so pregabalin, gabapentin, which are often really good for that neuropathic type pain. We've got benzos at our disposal, so things like clonazepam, again, can have a neuropathic benefit. Diazepam, that sort of drug, can help with pain that's caused by spasms. And also things like baclofen as well can be managed more effectively with that than opiates. Thinking about TENS machines, we might need to think about keeping somebody on mates, particularly if they've got bony type pain, and maximum response, again, in terms of managing patients' expectations, is not seen immediately. It's a few days after treatment. So it's making sure that people know that and that they're prepared for that. For some patients, things like complementary therapies, massage, and those sort of alternative type therapies can help somebody manage their pain, be that through distraction or just stimulation or just one-to-one therapy in another way. And also not forgetting things like physio and OT. So looking at practical support for how to move, perhaps more effectively making sure people have got appropriate aids and adaptations, again, that are going to help in that aspect of that person's care.
Jill, I'm conscious we've got 20 minutes left.
Okay, I will talk quicker. So we've got a case study up on there. So we've got a chap here, 62-year-old man with metastatic prostate cancer, starting to complain of continuous pain in his right hip. He's been taking cocodamol, 13/500s, 8 tablets a day. So he comes into your GP surgery. I don't know whether anybody wants to put anything in the chat or not, but it's just thinking about what our options for managing his pain might be. So I'll give you a couple of seconds if you want to type anything in. If not, I'm conscious of time and we will move on to some options. Not got anything at the minute, have we?
No, I'd move on, Jill, with the time we've got, thanks.
Okay. So we might need to think about getting some imaging done. We might need to think about an X-ray, particularly with this hip pain. We might need to think about things, again, our non-drug measures as such, like radiotherapy, if we think somebody's got metastases in that hip joint. So again, it's a consideration we need to make. 8 30-milligram codeine tablets equals 240 milligrams of codeine in 24 hours, which would equal 24 milligrams of morphine in 24 hours orally, which would give us a BD dose of 12 milligrams. Obviously, that dose we don't have available. Morphine is generally used first choice, oxycodone second line. And so we might need to think of an equivalent morphine dose of slightly greater, which is what I would go for. And I'd probably opt for 15 milligrams of slow release morphine. Happy for him to continue with his regular paracetamol. As I said before, that can help with that bone type pain. And we might need to think about things like NICE guidelines in terms of driving if we've just started somebody on opiates, because we want somebody to be safe as well. In terms of if we're starting somebody on an opiate, we need to think about side effect profile. So constipation is the big A. Nausea and vomiting, often when somebody first starts an opiate, is a transient thing. It will settle down within a day or two. Respiratory depression is uncommon as long as your dose is commensurate with somebody's symptoms and you're not going in too heavy-handed. In 30 odd years in palliative care, I've only seen Narcan used twice, and that's been in exceptional circumstances. Drowsiness, again, just warning somebody they might feel extra sleepy for a day or two. If that persists, then you can talk to them about reducing the dose if that's carrying on. So at least you need to be prescribing a laxative and an antiemetic. When we think about opiate toxicity, we might see patients that present with things like hallucinations, drowsiness, pinpoint pupils, jerking or myoclonic jerks and confusion, in which case we might need to think about reducing somebody's dose, or if that's not effective, we might need to swap to a synthetic version of morphine, which would be oxycodone. And if somebody is just presenting with hallucinations but is otherwise okay, then we might think about a small dose of haloperidol at night and just monitor to see if that will help the hallucinatory effect. Patients with moderate to severe renal impairment, morphine metabolites can accumulate in the system. Oxycodone is a little bit kinder on kidneys and liver than morphine is. Again, you may see patients in renal failure who you might need to consider alfentanil or fentanyl. And again, depending where you are working and what drug you might see more commonly. So if you're on NOTS border, you're more likely to see patients discharged from NOTS hospitals on fentanyl rather than alfentanil, which is what we tend to find in Derbyshire. Again, those drugs are prescribed under specialist advice. We won't be expecting you as a GP to instigate that necessarily. And no, certainly these drugs are more effective in a syringe driver because they have a short half-life. So as a PRN dose, I would still often recommend oxycodone rather than PRN fentanyl or alfentanil.
And Jill, as Chris is in the chat, you can also use non-steroidal
Yes.
anti-inflammatories of the PPI cover. And I've had a patient in his 80s who had metastatic hip pain, and I got him under Chesterfield Royal, and he had a hip replacement, which sorted his pain out, which was also good. So people with metastatic bone disease can still have other treatments.
Absolutely, absolutely. So generally, it's morphine prescribed first line. That is your first protocol. Oxycodone second line, or in renal or hepatic impairment. And diamorphine we see less commonly now. May still have a use, particularly with patients on high doses of morphine, if you're looking at syringe drivers, because it's more soluble than morphine. But we are looking at really high doses. Again, the majority will be managed fine with morphine. So thinking about breakthrough pain and thinking about what it is, we generally prescribe a sixth of the total 24-hour dose of opioid. And we'll have a quick look on the next slide about how we might calculate doses for 60 milligrams of morphine, 30 of Oxycontin, and diamorphine in a syringe driver. So again, look at the Derbyshire Alliance website for advice on conversions. Generally speaking, when we're looking at morphine, we would add the total morphine dose in 24 hours. So if somebody's on 60 BD, that would be 120, and divide it by 6, which would give us our 20 milligram of Oromorph dose. And if we need a subcut dose, then it's 120 divided by 2. It's twice as potent by injection as it is orally. And again, our PRN dose of a just in case would then be that 60 milligrams divided by 6, which would give us our PRN dose of 10 milligrams. It's the same sort of scenario for oxycodone, just bearing in mind that oxycodone is twice the strength of morphine, but exactly same scenario in terms of working out what our doses should be. Morphine, diamorphine, you're more likely to see it in a syringe driver than anywhere else. Doesn't have an oral equivalent at all. So if you've got 30 diamorphine in a syringe driver, you just divide it by 6 for your PRN dose. Morphine, diamorphine should be prescribed with Oromorph if somebody's still got an oral route. If somebody is on oxycodone injections, then it should be oxycodone liquid, or if they've been on liquid and you're converting, then it should be oxycodone injections, just because of the conversion rate causes much less issues and errors if somebody is consistent in the drug that they're on. And yeah, I think we've covered that.
Jill also asked if you can explain how to use bisphosphonate infusion. So you don't only use it for people with raised calcium. It can be used for people with metastatic bone disease, people with osteoporosis, osteopenia that have got bone pain as well. So it can be used. Oral bisphosphonates are good. I did some research around oral bisphosphonates, but their life, their worthy life, I suppose, lasts about 6 months. So for their pain control, 6 to 8 months is the benefit that you'll get. You've got to bear in mind the side effects, although I've not seen much jaw necrosis. I have seen it in one person, which stopped them taking that. But you can use oral or IV bisphosphonates for bone pain, and it's a really good treatment. Thanks.
And you can also again, we're working with the 2 local specialist palliative care units as well. DHU Community Virtual Ward has instigated some of these infusions in community if patients really don't want to go to hospital. So just something to be aware of as well. So thinking about patches and syringe drivers, generally speaking, as a rule of thumb, we continue with the patch. A syringe driver is used to top somebody up. Much more complicated trying to convert somebody from a patch to a syringe driver, and would involve a couple of changes in a syringe driver over a 24-hour period. So we generally say continue with the patches and use a syringe driver to top up. So we've got a patient there on a 50 fentanyl patch, becomes less well. He's had one 30mg dose of Oromorph and two 50mg injections of subcut morphine. So if we were setting up a syringe driver, then his subcut equivalent dose would be 45mg, because the oral dose of Oromorph, obviously we will be dividing by 2. And it's thinking about those sorts of things when you are prescribing with somebody with a fentanyl patch for their just in case dose. Then you need to factor in what the fentanyl patch just in case dose would be, and any drugs that you've got in a syringe driver as well when you're doing the total. So going back to our case study, we start him on MST 15BD, went up over an 8-week period to 60mg of morphine. He's generally feeling better, but the times in the day when his pain is quite severe, and he's taking Oromorph 10mg PRN, and he's had 4 doses in the last 24 hours. So thinking about our options, we need to go back and reassess. We could ask patients to keep a bit of a pain diary to record the doses and effect. Type of pain, again, as we said, morphine's not effective for every type of pain, so we might need to consider an adjuvant. We need to increase his oral dose of PRN analgesia to 20mg, because 10 is not the recommended dose for the slow release pain relief that he's taking. We might need to discuss with him about taking his analgesia preemptively, so before movement, before something that he knows exacerbates his pain. And we could convert to a patch, but somebody needs to be on a fairly stable dose before we recommend moving on to a patch. So he's on MST 60BD, became during the day, but he's having reasonable pain relief as a whole. Number of breakthrough doses is varying every day from 1 to 4 doses of 20mg of Oromorph. So thinking about this chap again, we go back and reassess. His PRN usage isn't consistent. So if he were taking 4 extra doses every day, then I'd be definitely looking to increase his background analgesia, but that's variable. So although we could go up with that, it's likely to make him more sleepy, and we've already got that sleepiness is an issue. His pain is fairly well controlled, so we could convert to a patch. That's something we could think about, and the choice of patch dose would be 37. If that's what we were looking to convert. We could consider switching to oxycodone. It's got a slightly reduced side effect profile, but if he's been on morphine quite a while, then the drowsiness is probably unlikely due to that. So again, we might think about our adjuvant. We might continue on our regular dose of paracetamol as well. So just to emphasise, morphine is the drug of choice. It's nice and cheap and readily available. Oxycodone is our synthetic morphine, which has less side effect profile. So if somebody is complaining of some of the side effects from morphine, then it can be worth trying them on oxycodone. Fentanyl, as we've said before, comes in patch form. You may see it used in renal failure, particularly in Notts-Bassett Law area. Dimorphine is highly soluble. Alfentanil is the drug of choice for renal failure at the moment in Derbyshire. Methadone you might also see as a synthetic opiate, again, if people are struggling with the regular ones. You may occasionally see, but again, these would all be under specialist palliative care, patients on ketamine, and we've got things like ketorolac or paracoxib that we may see used as an injectable NSAID. So our drug dose is affected by our route. I think pretty much everything on there we've covered beforehand. Fentanyl conversions are up there on the chart in terms of, and again, are available on the Derbyshire Alliance website. Fentanyl is a potent analgesia. It's not suitable for unstable pain, and certainly thinking about patches, it's not something, if somebody's got unstable pain, we just need to keep whacking the dose of the patch up. It will take a good 12 to 36 hours in some patients to achieve peak plasma concentration levels. So certainly if somebody's got unstable pain, I wouldn't recommend starting them straight on fentanyl. We need to know roughly what their usage and what their requirements are before we go down that route. So there is a as I say, there is advice available there. And fentanyl, it's also worth noting, is a kind of drug for patients that have got liver problems than morphine is. I think we've pretty much covered what's on there. If you've got a patient on a fentanyl patch and they are still taking breakthrough doses, you can use Oromorph or oxycodone. Again, thinking about their history and what's worked for them. Occasionally, some patients will experience a patch issue where they've got an irritation from the site. You can try things like a topical steroid spray, something like beclomethasone, let it dry and then apply the patch, and you often find that those effects are less of an issue. So in terms of switching opiates, we would generally only switch if we are getting poor efficacy or intolerable side effects. You might need to think about that if you've got a patient then develops more severe renal or hepatic impairment. Might need to think about somebody who's getting cognitive impairment, so might think about a switch from Oromorph to oxycodone, or there might be a combination of those things above that make us think an opiate switch might be something that's useful. And as I said before, be consistent in your prescribing. If somebody's on morphine modified release, make sure you've got Oromorph prescribed. If they're on oxycodone long tech, then make sure you've got oxycodone short tech or immediate release liquid prescribed. So we continue with our patient on 60 of morphine BD and his 20 of Oromorph dose and his regular paracetamol. But his pain starts escalating. He starts complaining of burning pain in his right hip that's going all the way down his leg to his foot, describing it like walking with a pebble in my shoe. So again, thinking about options, we've got pain in an area that's causing altered sensation. So we may need to investigate that. We could be looking at imaging again. We can think about things like dexamethasone. We can think about amitriptyline, gabapentin or pregabalin. So gabapentin and pregab both need to be aware of renal function to start with. Gabapentin's 3 times a day tablet, pregabalin is generally twice a day. So it's thinking about tablet burden for people that you're caring for. We might think about our benzos again, and we've got some of those with anti-convulsant properties that we know are more effective for neuropathic pain. So things like clonazepam, but only for use under specialist palliative care guidance, and it does come in oral and injectable formulation. Duloxetine has also been proven to have got an a neuropathic pain, a positive effect on that. Ketamine is an anaesthetic, obviously used in low doses for pain orally, can be given by subcut injection. In Sheffield, we had one of our consultants who used to do it IV to start with before he converted to a syringe driver, but definitely under specialist guidance. And again, methadone would also be under specialist guidance, but you might see patients that have come out of either the hospice or hospital on those sorts of regimes. So our patient goes on to have an MRI of his spine. It showed that he'd got some nerve root compression. He's had some radiotherapy to his lumbosacral region and completed a course of steroids. He's still on his MST 60BD, his Oromorph PRN, and he's on gabapentin now 600 TDS. His neuropathic pain's controlled, still gets odd dull ache in his right hip, which is worse on movement. So again, thinking about our options, we could increase his opiate. We already said about NSAIDs before, in which case you definitely need PPI cover, need to monitor renal function potentially. Thinking about radiotherapy, if it's in a different area, generally don't irradiate the same area twice. Could think about bisphosphonates, as we've talked before, and as Pauline alluded to, one of her patients still can't rule out an orthopaedic procedure if it's felt that it's suitable and that patient is well enough to tolerate it. And it's also worth thinking and monitoring calcium levels in case for risk of hypercalcemia. So sadly, he deteriorates. He's unable to take his oral medication, and he's now become bedbound. He's not communicating very well. He's taking very little orally. He's complaining of nausea type symptoms. He's a little bit restless and he's got a coated tongue. So at this stage in our journey, we're making sure our just in case or our anticipatory prescribing is in place. So we've got up there on the screen, and the slides can be shared with anybody that wants them to look at in more detail. I appreciate I'm going through these very quickly now. So, as I say, making sure if we are looking at a syringe driver, it would be half the total amount of oral dose that he's taking, with a breakthrough dose of a sixth of that total dose as well. Diluent, don't ever forget to prescribe as part of your just in case prescribing. So generally speaking, it's water for injection, maybe an odd few drugs on normal saline, and to make things easier, there is work going on across the county that we are moving towards water for injection everywhere, including Derby Royal. So you're less likely to see patients discharged with normal saline. And there's also some new syringe driver compatibility guidance that's coming out within the next few months, hopefully, that will make things simplified rather than having different combinations in different areas. And we can also look to treat oral thrush as well. I've said about diluents, I've said about syringe driver compatibility. Write up your just in case end of life prescription sheet for the DNs. Please ensure there's a copy in the home from an out of hours perspective, particularly if our evening and night nursing service are going in and the nurses are just taking it off the prescription on system one, we are going to run into problems, and it causes delays in care because we may need to get a clinician to come out and prescribe a directive. Either way, the slightest bit, there will be convenience of having to get in touch with clinical lead and try and access notes electronically to make sure that we are prescribing in line with what's available and what you've already prescribed. You can think about recognising dying form, more commonly used in secondary care than it is in primary care, and please make sure you've got your respect form in place. Remember that holistic approach to care. It's about what's important to that individual. Make sure you address anxieties, fears, concerns. Think about the spiritual and existential side. Please make sure people have been given contact numbers for services in hours and out of hours as well. In terms of that Kalman gap, it very much applies to patients and relatives in terms of what to expect when death's approaching and what to look out for, and also what to do after death so they know who to contact. That's often a time of extreme panic for somebody. Good communication with patients and relatives themselves and with the rest of the team that might be involved, particularly, as I say, don't forget out of hours services, don't forget ambulance teams. We're the ones that will get called out of hours, and we don't want to go against your care plan or what's in that patient's best wishes. So make sure that documentation is clear, and also remember to look after yourselves as well. So there's useful resources on there. There's a link to the Derbyshire Alliance for End of Life Care website, and that's the end. That's not bad for 1 minute past.
Perfect. Thanks, Jill. Thanks for going through it. You will be sent these slides, this presentation. We send it to 117 practices, hopefully. If you can share it along with your colleagues, that's great. Has anyone got any questions? We've answered some of the questions in the chat about the use of bisphosphonates, use of dexamethasone over other medications. But yeah, any other questions before we let you go and have a cup of tea?
And if you've got any requests for further training, then please let us know as well. We'd rather put on things that you feel are really needed in your practice rather than what we think that you might need. So drop Pauline a line.
Lovely. Thanks, everybody. And we'll see you next month.